Here we are. Welcome to London, guys. Welcome to London. Dispelling the myths of IVL. So, I mean, this is something that we are trying something very new with all my colleagues here. We are trying to get what you think from your point of view. So, we're talking about shockwave. We are talking about the technology which is used now more and more. We're talking about the technology which has possibly some biases. So, I'm asking you, where do you think that IVL doesn't work? Where you think, this technology should be challenged? I'm asking you, where do you think that shockwave doesn't work? Subintimal is one thing. So can we please put the board on? So we're going to try to take notes of this. So essentially we can write down, we can try to address some of the points. So one is subintimal, then? Sorry? Long subintimal calcium. Long segment calcium. Okay, that's nice. Where nothing else passes. Okay, fine. We need to open. Okay. Then? Stent recoil. Okay, but that's out from IFU. Like, you mean like inside the stent? Okay. This is out from IFU. Okay, perfect. Yeah. Okay, but again, this is out from IFU. So it's like, it's good to challenge because, I mean, like, it's something that it's not supposed to work. Intraluminal. So do you mean the eccentric plaques which are coming inside the vessel, am I right? Okay. Okay, any other concern? Okay, should we take this? So we have August on the back. Did you take notes of that?
Yep.
Okay, good.
Here from the International Broadcast Center.
Okay, yeah. And Houston, are you there? Okay, good. So try to, which one do we want to start with?
I would probably challenge Ash. Do you have any case of eccentric lesion, Ash?
Yep, I think we can probably have a look at, oh, there you go.
We don't see it on the screen. Can we put the slides on the screen? Okay.
Okay, so I think it's a really good question. Eccentric lesions, are there other devices? Can you use atherectomy? But actually, the more we use IVL, the more we see how good it is at treating those lesions, increasing your luminal area. So this patient, CLTI, tissue loss, you can see the calcium just on the X-ray. And actually, at the top, you can see there's an eccentric lesion of the SFA, and then just distally around the adductor canal, you can see a couple of eccentric lesions. Not great runoff. And again, CLTI, one of the worries is when you have one vessel runoff, if you're going to be using vessel prep devices, you've got a risk of trash. So in this sort of situation, is there a device that's safe, that reduces your risk of losing the runoff target? So next slide, if we can.
You have the clicker.
I've got it here, right?
We can't control the slides. Okay, yeah, perfect.
So I've just shown you the top and sort of the adductor canal. So there's an IVUS pullback. If you have a look right there around 7 o'clock, you can see the calcium. There's an eccentric lesion. You see acoustic shadowing. So you have the segmental areas of another lesion there. That's an eccentric piece of plaque. So you can see how another one there at 2 o'clock. That sort of eccentric calcified lesion, and it's these lesions that you want to tackle and see if you can increase the luminal area. Let's go to the next slide. So based on IVUS sizing, we're now using an appropriate sized balloon. So we tend to use bigger balloons than you might expect because of the IVUS. So I've used an 8mm shockwave balloon treating that eccentric lesion.
Just a second, Ash. Yeah. So I mean, you have shown us you're inflating an 8mm balloon into the SFA. So how many people would inflate an 8mm balloon in the SFA? Good. I mean, I was expecting less because I mean, like, I think this is something that we need to address. I mean, we need to address two things. First of all, you said the IVUS allows us, or a CT or something, it allows us to understand the real size of the vessel. And the second thing is also the sizing of the shockwave. Do you,
And
Ryan?
in these eccentric lesions, actually, oversizing is even more important than concentric calcium, because you have to get the balloon to wrap around all parts of the coralline plaque. You have to move the position of the balloon slightly between each cycle to change the incident angle of the shockwave on the plaque. And that way you can get good results in eccentric lesions.
It needs to develop that lesion, doesn't it? That's the whole
It needs
point.
to cover the lesion as much as it can. So
Okay,
that
but are you not worried about dissection in this case?
So, a good question, because the eccentric lesions without vessel prep do dissect. We know that they're the high risk lesions. Concentric lesions have a low risk. Remember, with shockwave, it's low atmosphere. It's not actually an angioplasty. All you're doing is just giving apposition to the lesion, and it's the energy that you're imparting is what's treating the lesion. And then afterwards, you're using POBA plus or minus DCB. That's the point at which now, because that plaque is softened, it's more malleable, you have reduced dissection risks. But these are the lesions where you do get dissections. And that's where I think that shockwave really comes into its fort. Distally, I actually use a slightly smaller balloon, but even then, at P1, it's still a 7 millimeter shockwave balloon based on the vessel size.
Ash, why didn't you use the same balloon, the same IVL catheter?
Yeah. So, I'm sure we can talk about cost. It's about imparting how much of the shocks I'm going to impart on certain lesions. This patient had multi-level eccentric, a few lesions. I wanted to maximize the treatment and make sure I didn't undertreat one lesion, and then essentially treating both sort of halfway house. There's no point of that. So I was much more comfortable treating both lesions effectively rather than both sort of 50%.
But I think the point that Michel is also getting at, that if there was less disease proximally, you would have happily used the 8 millimeter balloon to treat that bit, because you're not inflating it to a pressure where it's exerting force on the wall. It's just a medium for energy delivery. That's all.
Who's worried using the 8 millimeter IVL catheter in the distal SFA or popliteal region?
Red flag.
One.
Okay, the next will be then your case where you're using the 8 millimeter downstairs. Okay, please go on.
Yeah. So I think you've got a great point there. The balloon just opens to what it wants to open at 2 atmospheres. It's not going to actually angioplasty there.
Do you look at the atmospheres on the thing as you're inflating it?
No. So that's the other thing. So you're told to look at the atmospheres, go to 4, and then go to 6. Actually, what you're looking at is the balloon opening and it enveloping that lesion, and you've got apposition, and that's the point at which you stop, and that could even be at 2 atmospheres. So you're not actually stretching this vessel open at all. We've lost control of the slides. So.
Yeah, can we move one slide, please? Because we lost control on the clicker. So next slide, please.
Okay. So in my practice, I use DCBs a lot, and in the situation of solution, keep going. Next slide, please.
Next.
It's interesting to see. I mean, like the fact that there's the pre-angioplasty with the 5, and then you go DCB 6.
Yeah.
Okay, that's something very important. I mean, personally, I wouldn't go 6 and 6 because then you don't have enough wall opposition for the balloon. So if you think you're going DCB, predilate with something smaller, and then go with despite you already use the shockwave, but in the long segments, then you use a smaller balloon.
So
and
this
you can see
definitely
there's no dissections, and those were high-risk eccentric lesions. So to answer that eccentric lesion question, I think it has got a role. It has got a really good role in those types of lesions.
This is definitely an amazing.
Okay, I think that the best now is to go to switch. Because we're talking about size. Am I right? So let's switch to the case of Michel Bozier. I mean, he brought a case where actually oversizing is key. Okay, this there are 2 cases. One is this one, and the other one is SFA.
So this one was a CLTI patient with a single runoff of the peroneal artery, where I used a 4 millimeter IVL catheter.
The next one.
All the way down onto the level also here. This one here. And without any dissections. I didn't do a post-dilatation with DCB because, again, no studies were telling us how to do or how to treat the best way in a BTK segment. But the case I wanted to highlight was this patient who had 2-level disease. He had a common femoral artery calcified plaque. I talked extensively with the patient about both options. Still, I'm a vascular surgeon, so endarterectomy is my goal number 1. He wanted to try, knowing that it could fail the endovascular way. And he also had this strong calcified lesion in the popliteal artery at level of the P2 segment, which you can appreciate, especially on the third picture from the left. Cost and money and time is also an issue, so I decided to go with the biggest size balloon I needed for the common femoral artery and stick it in the popliteal artery as well after pre-dilatation, because as mentioned before, sometimes you cannot pass it with the catheter, so you need to pre-dilatate with a 3 millimeter or even a 4 millimeter low profile balloon catheter, and then you can put in the 8 millimeter IVL. You just inflate it until 2 atmospheres. It's just necessary that you have your wall apposition with the balloon, as NT already mentioned. You need to have the apposition of the vessel wall surrounding the entire calcium. And then afterwards I DCB'd it with a 6 millimeter, and in the groin I DCB'd it with an 8 or a 7 millimeter with an excellent result without any dissection and no need for stenting.
Excellent flow, yes. I mean, I think it's important also to understand what you want to achieve. You want to achieve, and it's what Stefan also is publishing with you. I mean, I think like with the vessel compliance or the pulsatility of the vessel. I think even if the calcium is still there, no one removes it. But if the vessel becomes with the same amount of calcium, I usually say as a windscreen. You know, the windscreen is very difficult to open if you're inside of the car, but if you crack it and then you push. Like this is something that
It's very interesting to see, and I can all of you want to go to Luca Gariboli in Verona to the cadaver lab, where you can train on shockwave as well. And all the ones of you are vascular surgeons, if you look at a vessel, a calcified vessel, you can't compress it. It's like a rock. But if you use the IVL, because of the micro fractures you're creating, you can occlude the vessel again with your fingers. So you take it out of the cadaver and you compress it again without any problems. It's really, really impressive.
And then the whole point is you make it compliant. So then when you do your POBA and DCB, then you get luminal gain, isn't it? Whereas if you did it without the shockwave, it'll just recoil on you straight away, and you won't get any luminal gain.
Thanos, a comment?
Yeah, this luminal gain concept after IVL, especially in the common femoral, I always struggle to actually see any proper luminal gain in the way that we've been trained to see a luminal gain. So I think it is quite important that, especially in the proximal SFA and the common femoral, you do your quality check at least 2 or 3 views, but in my hands probably best with ultrasound. So get your ultrasound out to figure out exactly what you've done after the IVL. If you've got IVUS on board, that's great, but I think sometimes, especially in the big arteries, you don't immediately see a luminal gain. You just see a change in the behavior of the artery wall, which is extremely difficult to quantify just by one view.
This is a very important point, and that's why you have to look at the triphasic wave, which also Stefano is always showing on his very nice presentations. So this patient, this was done in September. He's now coming back for his other leg because he has an incident occlusion. But actually still has triphasic flow, SFA, popliteal artery. So this is a great result without the need of stenting. So don't be afraid if you see, oh, the calcium is still there, I need to put a stent in there because I'm told and I've learned to have maximal vessel expansion and luminal diameter and stuff like that. It's the way the vessel behaves. It's an ABI of more than 1. He has no pain whatsoever in his left leg. So it's don't put in a stent if you still see the calcium. The calcium is not going to go away.
Yeah, I think the pulsatility, I mean, you need to think about how the vessel thinks, how the foot thinks. Thinks about the flow, thinks about, the blood which goes down. That's probably, especially as interventional radiologists, probably we're usually biased by this kind of training, as you said, with imaging. Like we need to have the perfect image, and what's better than a stent to show that the vessel is perfectly patent. But, then stents have their own problems. So
guys, somebody has mentioned something about long lesions.
Also, I mean, what I want to tackle also is like we were talking about CTOs. Am I right? Someone said CTOs.
Yeah, someone has mentioned CTOs. And come on, you are the Italian stallion. Do you have any case to show us?
Yeah, I mean, show us the case of CTO. Okay. Because I know we know that this kind of thing is like these are the most interesting ones. So, for example, this is a patient I treated with a quite long CTO, and you can see here that at the level of the popliteal there was also a knee joint replacement. And I of course, do all my angios, to understand perfectly what's the landing point. I also did another projection to see if the popliteal artery was fine without the knee joint prosthesis. And you can see here that this is a typical patient that you don't want to embolize, because there's a single vessel runoff, which is this peroneal, which actually goes down to collaterals. So this patient, as you can see, is under local anesthesia. It's something that you don't want in a rest pain patient to embolize this vessel, because if you trash this vessel, you pass from rest pain to probably, acute limb ischemia of the foot and possibly amputation. Because if you trash really the peroneal down, then it's difficult also to suck out the thrombus and to regain the collateral. So I couldn't cross with any wire, and actually this is where I think that's a good tool in order to cross these lesions. You can see this is a go-back catheter. So the go-back catheter was advanced as a knife. You can see how much calcium there is in this artery. I think that no one can really argue that this is a lot of calcium. And you can see how I changed the projection. LAO 37, so the tube on the left, and RAO 42. And then, I continuously change in order to check in two projections the advancement of my device. You can see that I'm pushing, and you can see also when I'm pushing how the artery itself moves. So essentially, I push through the artery. You can see how the artery is affected by my pushing, but I still go with this kind of needle, which can be, of course, angulated towards one side on the other side, until I reach a point where I think I could advance. You see how I'm advancing my wire. Now I'm pretty sure that I'm in the right place, because again, it stops there. And despite I'm trying to advance, it's not feasible. So I stop, and I remember that this is like a catheter. Oh, sorry. It's like a catheter, so essentially I can inject contrast from this device in order to get the... Yeah, but why it's not moving? Okay, I can inject contrast in order to understand where am I, because essentially we know, and we said that before, that CTOs are not always complete occlusion. They are like caps of calcium or occlusion, and maybe there's just a tight stenosis there that I couldn't see before. By injecting from the catheter and advancing then my guide wire, where I know that the vessel lumen is patent, I'm able to cross. And you can see here that the vessel is not completely occluded, but there's very strong spots of calcium. And this is where, as we said before, I prefer in this kind of also quite large vessels to advance, first of all, a low-profile balloon in order to create some space, for then having the lumen a bit open in order to advance my shockwave balloon. So you see, this is after pre-dilatation. It's a long calcified lesion. I don't think that this would have been treated by POBA. Would have someone treated this lesion by POBA only? Or other type of vessel preparation? Would someone use atherectomy here?
Atherectomy is not going to be that successful in a heavily calcified lesion, and then other types of calcium removal is risky in terms of embolization.
And are you scared about the distal vessel?
Absolutely, you got one vessel runoff.
One vessel runoff peroneal. Gregorios, can we have a microphone? Sure, intraluminal. But first of all, I'm not sure I'm intraluminal here, because I advanced my needle through and I'm not entirely sure. And second thing, I'm really scared, personally speaking, of the single vessel peroneal runoff. So this is why I use shockwave. And you can see here that by using shockwave, of course, it's a 7 millimeter by 6 centimeter balloon, and I'm inflating it fully, slowly, I can get this result. And then I forgot that there was this lesion. So, okay, fine, I can come back still with the same device, and you can see in this video how the device works. I start putting the shocks, and you can see here at this level now, 1, 2, 3, the balloon pops and it opens. Even with me keeping at the low atmosphere. So essentially I'm not increasing the atmospheres in order to increase the stress on the vessel. I'm just relying on the pulses of the shockwave to open this calcified lesion. And you can see here again in another projection how the lesion looks like new. And the thing is, the good things is you see the single vessel peroneal runoff has still complete patency with all the collaterals bringing flow to this foot of rest pain patients. So I think it's something that in this case shockwave has been effective, definitely, and safe. And I can tell you the patient still has her leg and is going well.
So Lorenzo, this is...
So do we want to tackle something else?
This is definitely amazing, but still a lot of concerns within the audience with regards to the subintimal behavior of the balloon. So Nayaran, do you have any answer for that?
Who? Narayan?
Nayaran, yeah.
Perfect. Let's choose a case of Narayan.
Yeah, let's look at this subintimal case. Click up.
This 15.
So think got to be careful of the question that we're asking here. To say IVL doesn't work in the subintimal space, well, if the shock waves hit calcium, it's going to work and do a job. The question is, are you going to get as much efficacy as intraluminal as you are subintimal? Well, no, but it still works when some shock waves hit the calcium. So let's look at this case. This was a guy, contralateral amputee in his early 60s, now with CLTI on his remaining leg, and he's got this really dense calcified plaque at the origin of the SFA, which is basically creating a functional occlusion, and then he has this massive rock in the distal SFA. So that kind of rock, nobody's ever going to be able to cross that intraluminally, no matter what you try, B-back, go back, Astato.
But did you use a pen in order to draw to draw the calcium?
It's pretty dense, right? So we managed to cross the first one with a little retrograde access and cross the SFA origin lesion intraluminally. But by the time we got to this one, there's hardly any control. You have pushability but zero control. The wire goes subintimal, we go around, have to predilate to get even an out back in and get back in.
Does anyone come back? Does anyone have any doubt that we are subintimal here? I think it's so clear that it's like from how the balloon behaves and the
I don't think there is a subintimal plane existing in that segment of vessel. It doesn't exist anymore. It's just one lump of calcium. So we cross over through here and do the IVUS here, and you can see on the distal lesion, I've gone a little bit fast here, but we're in the subintimal channel there. And then you go up and there's some more disease of the proximal SFA that we've managed to stay intraluminal with. So just to go back to Dr. Bislas's points earlier about IVUS re-expanding collapsed stents, I think the key is to never let yourself get into that situation in the first place where you've deployed an under-expanded stent that you then can't expand, because you're right, we don't have any good tools to fix a stent that's been put in badly. And for that reason, looking at that distal SFA lesion, of course that lesion is going to get a stent. There is no way that this patient, who already, by the way, contralateral amputee, he's got 4 out of 5 toes are necrotic and he needs a transmetatarsal amputation. You get one go at revascularizing this patient. If you mess it up the first time, he doesn't have enough foot left for you to keep trying and re-intervening. You need to get it right the first time. So he's definitely getting a stent. But what I want to avoid is having a poorly expanded stent that we then can't fix. So in this case, we chose to use IVL for the distal lesion and the proximal lesion as well. Just to go back to what we were talking about, eccentric lesions. So you can see the balloons wrapping around, slowly inflating as we do, both the distal and the proximal lesion. And then when we eventually put in our plain balloon, that's just a bit of wrap in the balloon there. You can see the plain balloon is opening better, not fully, but it's opening better. But what the shockwave is allowed to do, even though we're sending a lot of the energy from the balloon just into the soft tissues, some of the energy is going to the plaque, and it allows us to deploy this supera properly and end up with this very, very rapid increase in flow just from treating those 2 short lesions. And I think this is a case where without the IVL in the distal lesion, I wouldn't have been able to get that supera to open properly. You can try all the tricks you can, deploying slowly, slow predilation, but that rock was just too solid. It needed something else to allow us to place a proper supera there.
Yeah, I think also, to prepare the vessel, it's not bad. I mean, if you want to prepare for standing, it's not like you're not losing. You're just winning by positioning a stand and not falling in what Theo was saying, like having a stand which is then not very well deployed, which is, I think, the worst. I think if I can think about the worst scenario in my cases, it's a stand which is not very well deployed.
You can't fix it. There's nothing.
Exactly. So we all agree. And do we have another? I think I have a case also of CTO and eccentric. Am I right? Because I think there's also an interesting case I can show. Because again, the subintimal, which is one of the no, it's not this one. This one again isn't right. Show me the one I do have about subintimal and eccentric, because I think it's important to tackle both problems. And essentially, when we think that the balloon is not in the middle of the vessels, both subintimal or eccentric. And I was lucky enough to use this technology in one single case where I had both the eccentric lesion above and then the total occlusion, the chronic total occlusion lower down. And I think this tackles both problems. It's not this. If you,
11.
I don't remember now the number of slide. Oh, in the meantime, Thanos. Oh, here we are. Okay, so I think this is the case I want to show you. So this is the case where actually we all agree that there's an eccentric lesion up there. Am I right?
It's okay.
And there's a chronic total occlusion here. If I show you this image, it doesn't look that calcific. It looks like pretty okay. But if I show you this, when I go with a recanalization with a better, let's say, view, you can tell definitely there's a lot of calcium. And you can tell that the crossing was very difficult because I had the 4 French sheath here, the 4 French catheter, the micro catheter, CXI, and the guide wire. And actually, I think that it's pretty obvious that here, again, I'm not intraluminal. Because, I mean, look at the guide wire, how spiral is around the lesion. And you can see here that I'm pushing and finally I re-enter. So again, it's a chronic total occlusion with like a subintimal crossing. In the meantime, I will finish this slide. You can see again, I crossed and I angioplasty with a 3 millimeter balloon in order to allow me to pass the shock wave. What's your comment?
Lorenzo, what about directly retrograde puncture in order to be sure that you stay inside the lumen, intraluminal?
I mean, yes, this could have been a case. I mean, the vessels are pretty small, which I love retrograde punctures. And I also think that because of the calcium, it's not going to change. I mean, it's very difficult to navigate these lesions anyway intraluminally, because you see there's a lot of calcium. So it could have been an option, but you know, the patient was on table, I push with the wire, I find my way subintimal, and I said, why not?
But your personal feeling is easier to stay intraluminal with retrograde puncture, or it's the same?
Yes, but I think the subintimal is a great tool, and I think it's easier to stay intraluminal. But in my little experience, with this amount of calcium, I don't know if it's your experience also, it's always difficult. You know, you can even take a lateral approach. you will never really go very easily intraluminally.
I agree, Lorenzo. So I think you know, you don't always have to stay in the lumen. And to be honest, because of shockwave, you now have the option of saying, I'm just going to go subintimal here, and I'm going to use IVL anyway. So it allows you to you know, get on with the procedure as well.
Because I think this is also the good thing about using shockwave in such a lesion. If you're subintimal, there's no atherectomy, I mean, at least from IFU, that you can use. So essentially, but to try to cross intraluminal is always better. But it's, in this case, I think when there's a lot of calcium, at some stage you say, you know what? Thanos, do you want to say something?
Yeah, just before I forget, I had a comment about the subintimal space discussion because NT did show a superior deployment. I think where we can get in trouble sometimes is to forget to do the POBA after the IVL, especially if you're using a superior. And that's another point where I've learned the hard way that actually in the subintimal space, yes, IVL does do something, but if you're about to stent, then you need the POBA as well.
Vessel preparation to the right diameter and cracking. Of course, you try not to crack, and this is why I tried. I mean, here I was ready to deploy a stent. You never know. You know, you try to prepare this very calcified lesion at best, and you see what happens. And I was lucky enough not to have my slides, but to have a good result. You know, I put the shockwave balloon. I used a 6 millimeter. The vessel here was not that big. It was a woman, and actually you can see here that this is the space where the very eccentric plaque is, and you can see here how I'm putting the marker, which is in the middle at the level of the most calcified eccentric lesion, because this allows you to give more than 25% value to your shocks compared to the other ones. So essentially, if you have a single lesion, stay there and use a hammer with like your middle marker as a hammer on the vessel. You can see here, this is the final result. Can you play the video? And because it's nice to see how both the lesions are gone. Why these videos are not playing? Oh, it was quite important. You can't play the videos? Okay, I mean, the videos are, anyway, it's funny, I can show you in a separate session, but we can put a picture, but it's like the calcium above was completely gone. So essentially, you can't see anymore this eccentric plaque. And you can see also the patency at the level of the distal SFA is great. And essentially what we care, and we said before, I mean, even if you don't see the images, which were very reassuring, together with the no distal embolization in these very low diameter vessels, is that we have a very good flow distally with less than 50% disease in the SFA pop, where the very calcified occlusion was. I can't control anymore anyway. And we have biphasic signals into the proximal tibial vessels, which is something that we look for. And if I show you other two slides, I can show you also the fantastic thing, which is the result, the clinical result, because it's something that we always need to keep in mind. Okay, this was how the foot was, and this is how the foot was after the treatment. So essentially, the improvement of the flow definitely brought some value to the clinical thing, and I think it's a great success. So I think the time is a bit short. I want maybe to present one single other case. What do we show? Like maybe a long occlusion?
Yeah, probably. I think we have excellent midterms and outcomes, but people is wondering about long-term durability. So NT probably has something to say.
Long term. Okay, Thanos. What's the speaker for that?
NT.
Okay, Narayan.
Yeah, I think let's have a look at long-term durability, because in heavily calcified lesions, durability is the problem, right? Like any other technology we know recoils quickly. Thanks.
Probably in the meantime, we upload the clip. Thanos can enlighten us about long-term data.
Yeah. Let's put the slide up if we can. I'll go through it very quickly. I think maybe slide 51.
Okay, because I mean, it's something that we try, to serve whatever you would like. So we put like many cases, and we are trying to manage through the slides, which is something new, but it doesn't come without any kind of struggle. So also, if you can raise the volume a bit of that microphone in order to hear better. And here we are. So let's put it on the screen.
So this is a case that some of you will have seen before, because I presented this one right near my start of experience with Shockwave. And I've been using it long enough now that it's starting to get long-term follow-up on some of these patients. And this is a patient we previously treated with atherectomy, had some trash, fixed it, very distal toe wound healed, and then came back with restenosis a year and a half later. And then we treated him with IVL this time, and it was a much less stressful procedure. You can see this dense calcium, this eccentric nodular calcium, very difficult lesion for other technologies, but this is actually where I find IVL most useful in my armamentarium. So we treated the lesion with IVL and POBA and DCB with a good result. Again, not perfect. There is some residual stenosis, but we've restored the pulsatility to the vessel, and what we see is that over the long term, that now looking very long term with these patients out to almost 2 years, that they recoil much, much less in the long term after treatment with IVL. So that's our initial result. Did a bit of work in the tibials as well, and we slowly worked our way through after the toe amputation to a healed wound, and now this is his duplex 13 months post IVL. And that SFA is still wide open as much as the day that we left it on the angioplasty. And this kind of durability without a stent, this patient, if I remember rightly, is in his late 50s, he's not old. This kind of durability without placing stents in CLTI patients is something that we're not able to achieve with other things like atherectomy or stenting.
And okay, so I mean, I think it's time to wrap up also because the stomachs are empty. So Thanos, I know that you're writing a consensus about IVL. Do you want to give us some highlights about this, and also looking at what we have seen today?
Yeah, but it's not just me. A couple of things really. With regards to evidence, there's a big cohort study with 6 and 12-month data coming out from the UK, mostly CLTI patients. We'll be presenting at Charing Cross, and there's a paper in the European Journal, hopefully very soon. I think NT has recruited most of the patients in that study.
Actually not.
Really?
Yeah. It was the Wales guys. Congratulations,
yes,
the 20 patients.
Right.
That was a really good job.
Good point. And we're trying to get a consensus statement together about use of IVL in the FEMPOP segment. There's lots of people involved, I think everyone in this table, and Lorenzo, and that will be coming out later in the year. So what's the best use of IVL, and what's the best strategy pre-op, intra-op, and post-op? And in terms of wrapping up this session, I think the cases were amazing. I think IVL does now have its place. It does have data to support its use from at least one decent efficacy-driven trial and a few cohort studies now. And I think, as we've seen, there's a bit of a learning curve, but once you get your head around it, it's an excellent tool.
I think it's a very wise comment. So I think with that is a wrap-up for the morning. Thank you all for your attention for this very animated morning, and let's all go to have a nice lunch. Thank you so much.